I'm here just simply to introduce and explain a little bit about this session. It's a two-part session. The first part is a panel, and I'm going to say more about that in a minute. The second part is an interview. I'm going to have the pleasure of talking one-on-one with Gary Wolf from the Quantified Self, and something I'm very passionate and excited about, so stay tuned for that. That's at 9:25. But first we have a panel, Voices from the Community, New Delivery Models and Demand for High-Quality, Affordable Care. Now, sadly for us, the moderator for this panel, Jay Sanders, took ill yesterday and is not able to be here, but happily for us, if you were here yesterday and heard Eileen Bartholomew from the X Prize Foundation give an amazing talk. Eileen, who's just really a very special person because she just said, oh, I'll do it with no prep, has agreed to moderate this session. So I'm going to turn it over to Eileen and her colleagues, and then I'll be back here at about 9:25 to do my interview with Gary.
All right, is this working? Thanks, Doug. Great to be here, folks. Thank you so much. I'm subbing in for Jay and going to have a lot of fun, hopefully get all of you involved as well. So I'd like to take a few minutes to introduce our panelists. Barbara, why don't you get us started?
Oh, sure. Is this on? Yes? No? Yeah, okay, great. It's great to be here. So thanks for Joe Cernulo and Joe, the folks at the Connected Health Conference. My name is Barbara Rabson, and I have been the Executive Director of the Massachusetts Health Quality Partners for the last 13-some years. And MHQP, as we call ourselves, is a broad-based regional health improvement collaborative where we bring different stakeholders together to improve the health of the residents of Massachusetts, improve the patient experience of the residents of Massachusetts, and we've just recently added to our mission to improve resource use to the care in Massachusetts, and also we have a new initiative to engage the public in the work that we do to measure and improve the healthcare in Massachusetts. And so delighted to be on this conference. I also want to mention that MHQP is one of 16 communities across the country that is a Robert Wood Johnson Aligning Forces for Quality community. Robert Wood Johnson sees the value of local efforts to improve care and bringing different stakeholders together, and they have a model where they bring performance measurement, quality improvement, and patient engagement together. And so this is an initiative that we've been involved with in Greater Boston for the last year and a half that MHQP is the operational home for. And one of the really wonderful things is the emphasis on consumer engagement, patient engagement, is that we've been really moving more towards trying to integrate the health system with community services, working closely with the Boston Public Health Commission and other local public health departments. So let me stop there.
Thank you so much. Diane.
Well, good morning, everyone. I'm Diane Stollenwerk, and I'm Vice President of Community Alliances for the National Quality Forum based in Washington, D.C. But actually, my heart is out in the community, and my work is in the community. For a number of years, I was the head of marketing and government relations, strategic communications for 3 different Catholic health systems. I represented the sisters. Sometimes people wanted to call me Sister Diane, and I'd say, no, 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 no. I take it as a compliment, but no. But I was doing that all along the West Coast in Alaska, Oregon, Washington, and California, and really working on ways to improve the healthcare system. Did that for, like I said, a number of years. And this was when people just started using the internet, and I was asked to develop the internet strategy, and a lot of people were talking about it as an electronic ad. You know, just put together something really nice and we'll just get a place. And I'd say, no, it really needs to be about operations. We've got to use this ability to make our connections better. And it was a really hard sell. And I got to a point where I decided the only way to fix healthcare is to nuke it and start over. It's not a really good professional opinion or a professional approach on the job. So I actually left healthcare and went into high tech. And living in the Seattle area, I was working for a software firm doing competitive intelligence work. And so what I did was work with folks in many different industries where we were collecting information from disparate sources, pull it together, and then using that information on the competitive environment for mergers and acquisitions, product development, competitive selling. Well, then I got pulled back into healthcare, and I was asked to start or help start the Puget Sound Health Alliance, which is basically a sister organization to Massachusetts Health Quality Partners, but we were focused on the Pacific Northwest. And we, too, were one of the aligning forces for quality communities, and as Barbara said, there's 16 of them around the country. We did that for several years in terms of pulling data together, putting it into a format where people could use it for decision-making, to make better decisions, more informed decisions in healthcare. That got into the arena of health IT in terms of the data sources, and then also how do you connect with consumers, how do you connect with individuals, and then also what do we do in terms of improving the quality of care. And so we were doing this as a multi-stakeholder collaborative. Eventually I started getting asked to go and help folks in Buffalo, or talk to some of the people in Memphis, or talk to folks in Utah who were saying, well, how did you do that? How did you get up and running? And then eventually the National Quality Forum called me and said, we would like somebody to come to the national level to help us really understand what's happening in communities across the country. So I decided to be an exchange student, moved to the East Coast. So I've been in Washington, D.C. now for a year, which is like a very different culture from the West Coast, I have to say that. But I spend a lot of my time on the road. I was in Kansas City recently. I've been spending time with folks in Maine and Cincinnati and Detroit, in Kentucky, in San Diego, and to really understand what their needs are in terms of the market structure. I also work with state leaders. I spent the entire day yesterday with a number of Medicaid leaders from across the country looking at shared decision making and how that might be woven into the Medicaid program and such. So it's an interesting world and an interesting time, and every market's a bit different. So very much looking forward to this discussion.
Thank you very much. You know, a lot of people have used a lot of terminology around what the problems of the healthcare system is, right? We all know that costs are going up, quality is being effective, access. And in this case, in this panel discussion, is talking about voices from the community, voices of all types, both physicians, providers, payers, and patients as well. You know, some of the drivers of patients in the marketplace today are changing things like consumerism, globalization, access to more information. People are used to getting that information anytime, any place, anywhere. What are some of the other drivers you think are important for a patient voice in this community and in this new model of delivered care?
I'll start. One of the things that's through some studies that we've done both at the Massachusetts Health Quality Partners and an organization that merged into MHQP recently, the Partnership for Healthcare Excellence, we've learned is that language really matters, and that to communicate with people, words resonate, mean different things to different people. And I think one of the challenges of engaging, even the idea of engaging consumers, the idea of calling people consumers. We had a recent forum of talking about engaging the public, engaging consumers, and there was an incredibly articulate woman, a two-time cancer survivor, that stood up and said, basically, how dare you call me a consumer? When I go into a hospital, the idea that people would consider me a consumer of services makes me sick. That I am there to be taken care of. I'm there because I'm sick. I want to get better, and that I'm not there to consume. I mean, the notion is really quite appalling when you think about it. So people are in different places. I think the whole term consumer was given to empower patients, because patients implies you're sick, we're well, we're in control. But then things evolve so much. So the idea of saying, don't call me a consumer, I'm not here to buy things, I'm here to take care of myself. So that's just an example of language that we've discovered. And there's so many different ways that different stakeholders that you mentioned view topics, words. So, for example, our board went through a recent strategic planning process and revised our mission, as I mentioned. And so one of the words that we used was affordable. We want affordable health care, which felt like a pretty positive, acceptable word. Apparently, on the physician side, affordable meant you're cutting my costs and you're changing my prices. And MHQP's worked on quality and resource, and we weren't working on prices. So all of a sudden, this connotation of affordability, it becomes an issue with different stakeholders.
Sure.
And so we run across that all the time. And so running a multi-stakeholder group, as I do and Diane has done, it can be really challenging because we're trying to bring people to common space and get to a good place. And so another example is that's a really loaded concept right now that we've talked about yesterday with the ACOs is choice. Mm-hmm. And so the idea of people want choice, we've heard from other speakers in the 1980s, managed care blew up because there was no choice, and doctors told their patients, it was a bad thing. Patients sometimes felt it was a bad thing. And so everybody, this is America, we need choice. But the whole concept of better coordinated care is sort of the antithesis of choice. Mm-hmm. It means you go through a system, you stay with the clinicians that know you, know your history. The care is coordinated because people talk to each other, they're all within a network. And so the concept of choice is, that's not the most important thing.
Yes.
And so the idea of how to communicate with that, how do you understand, how do you educate the public about, I want to do what I want to do, I want to get the best health care for myself, and I'm assuming the best way to do that is to go to the doctors I choose when I choose. Mm-hmm. And that's not necessarily the case. So it's a huge challenge. And another aspect, one more example about choice is that we pulled a group together in Massachusetts of different stakeholders about what do we want to communicate to the patients about, to the public about healthcare reform, because we're in the midst of payment reform and delivery system change, and everybody says yes, and I will engage the public, and we want to make sure the public is informed and buying into this, and so what we. One of the issues is that somebody said, well, are we talking about federal reform or state reform? Mm-hmm. Because on the federal level, as you heard yesterday with the accountable care organizations, people are told they can go anywhere. But on the state level, our health plans are saying, look, we're going to have very limited networks, so you can't go anywhere, everywhere. And so, just within communicating this message of, who has choice, what choice is, what's good to know, and where it is, are you talking to me, or are you talking to my mom, or are you talking to my daughter? It gets really complicated. So I don't think I've answered the question, but I've raised them.
And Diane, I'd like to also ask you to follow up on that. You've looked at it from both levels, right? State and now at a federal level.
Yeah.
Help me understand that.
Absolutely. And Barbara and I have known each other for a long time, so I'm going to push back on a couple of things that she mentioned, partly because it's just sort of the reality. We're living in a messy reality right now, a messy environment, and that's my professional term for it. The issue of how do we engage patients, individuals, consumers, people in this discussion and in this evolution is essentially important. It's essential. Individuals at certain points may not consider themselves consumers. They may say, look, I am a patient. I remember one of the early days with the Aligning Forces for Quality community meetings, and there was one of the speakers kept using the example of epilepsy, and he said, well, epileptics do this and epileptics do that. And several times I stood up and I said, my son has epilepsy, and he's a person who happens to have epilepsy. So I totally get that reaction of mama bear with a baseball bat, don't call my son that. At the same time, there is a real cultural push, particularly coming from the purchaser community and the health plan community, to say, how do we shift people's mindset to stop being so passive, to be more aggressive, to think of themselves as somebody who has market power and has choice and really should act like a consumer in certain settings. So when you're choosing where you want to get your care, or you're trying to decide which is the best hospital, if you have choices of hospital, in terms of which one to go to get the hip replacement, you're looking not only at, hopefully the quality aspects of it, but you're looking at the affordability aspect, which that's a fascinating story about the word affordability. But so part of that is at a national scope, but I think in a community scope as well, depending on what stakeholder you're talking to, they really want to engage individuals to become more consumers in certain settings. So it is certainly a language choice. I absolutely agree with that. But I think the right wording and the right language depends, it's context sensitive. Mm-hmm. So I think we need to pay attention to that. And we need to pay attention to the context, too, of choice. Individuals want choice. I know I want choice. I don't want to have somebody tell me I can't go to where I feel is the most appropriate place to go. But I think we need to have a more fine-tuned understanding of what kind of choice people are really hungry for or desperate for. It may not necessarily be choice to go anywhere for anything, for everything. And if they feel like, you know, I'm working with a care team that's a great care team, I may be totally fine with that. I may not want to switch care team because we know people want a really good relationship with their physician or the nurse or whoever they really have built that relationship with. That's a fundamental definition of quality care from the individual standpoint. So maybe what they want is choice in terms of after-hours appointments. Maybe they want choice in terms of how they communicate, or choice in terms of information about options, treatment options. So I think we need to fine-tune the notion of choice and our understanding of what people want, because that's the way we're going to be able to bridge, I think, the movement at the national level and at the state level to say we've got to have a different structure in healthcare in order to have this be sustainable. How we have things structured now isn't going to work. So as we move to new structures and new joint accountability and new payment systems, in order to have that work with choice, we have to fine-tune our understanding of what do individuals really care about when they say in a blanket way, I got to have choice.
We've talked a lot about patients, languages, processes. What also about some of the technologies that you think are helping assist some of these kinds of communications and changes? I'd be interested in hearing how you feel that's helping engage voices of the community. Maybe, Barbara, you can start us out with that.
Sure. One of the things that MHQP has done since 2005 is a statewide survey of patient experiences with care. And so we send out 250,000 surveys every 2 years to Massachusetts residents. And Rose Judge, who's our project director, is here today. We get 80,000 responses. It is unbelievably important to have this pulse of what's happening with patients as our healthcare system changes. However, it's way too expensive. Yes. And so right now we're looking to alternative ways, electronic ways to administer this survey. So we're engaging with a physician practice to do this survey, conduct it through a patient portal. This practice has a lot of, has a portal. A lot of patients use it, which is not necessarily the norm. We also have a physician who's here. I've seen Dr. Lester, who has every one of his patients' emails. And so he can, in fact, this kind of a good story around using technology is that he actually didn't believe the results when we shared them with him about how patients talked about his practice. And so he said, I'm going to do it myself. And so he put it on SurveyMonkey. He sent it out through email. He got exactly the same results. So it validated that, yes, this was indeed an important and valid survey. And so, but that was no cost to him. Mm-hmm. And so the challenge is we don't necessarily have patient emails. Patients don't all use portals. But what MHQP is doing this year is to look to electronic means of conducting this patient experience survey so that we can get access to what patients' experience is and be able to monitor that. There's some methodological issues when you use different modes of this, but it's an important way to go. And our next step, once we have this electronic platform in place, is to reach out and get patient outcomes. And so we can specify which patients have which diseases and follow up on that. So it's technology is definitely a huge help to us if we use it. It's hard getting everybody on the same boat and standardized. And listening to yesterday to folks saying that in Uganda it's a great place because there's nothing there and we have a clean slate. Well, we're the opposite of that here. So it's technology. It's a very crowded space, so it's really challenging to get people on the change same platforms. But that's something that we're planning to do with our physician partners in Massachusetts.
Excellent. Diane, I'd like your opinion as well.
Yeah. So similarly, an observation that I'm seeing at the community level, and then also I wanted to address that question or that issue from looking at what's happening at the national level. In terms of use of technology at the community level, the Aligning Forces for Quality Communities are all producing comparison reports, and those are available online. A number of them have Facebook pages, and they're trying to get the information out using different social networking techniques, either through Facebook or Twitter, sometimes LinkedIn. The Robert Wood Johnson Foundation is very interesting. They have, if you guys are on Facebook, friend somebody who is also on Facebook, Friend MHQP, there you go. Or you can friend me personally. I'm happy to friend you, right? And then you can be invited to the Transformation Has Begun group on Facebook, and that's run by the Robert Wood Johnson Foundation. There's some great information that ends up showing up on that page, but they've also started to use it to announce new grant opportunities, which I find fascinating, because not only is the grant opportunity put out there, but the leaders, the programmatic leaders within the foundation will discuss their intent and their interest and their changes, which is like golden information for anybody who's involved in development to get that insight internally. So it's called Transformation Has Begun. I see a lot of people writing that down. Anyway, so I think that's fascinating because it starts to blend the personal and the professional within Facebook. As Barb was mentioning, there is a move at the community level to try and have more presence online. It's depending on what community you're in, the Pacific Northwest, the land of Microsoft and the land of, lots of high-tech firms. You've got presence of Group Health Cooperative, who's just done a fantastic job of really being much more accessible in an online way with email communications and working through the HIPAA issues and all of those things, with being able to have more of a technology foundation in how they interact with and care for patients. A large percentage of their patient visits are now via email, where the diagnosis and the advice is provided solely through email, which has fundamentally changed aspects of their business model, whereas there are other communities where it is so not part of the community culture to do that. So we're all over the map, not only in terms of the communication, but also the data capabilities. The ability to pull together information from electronic health records or electronic medical records varies quite a bit from location to location. I've worked in some rural areas with provider groups, with physician practices, where the sole reason why they've adopted an electronic medical record is because they ran out of storage space. I mean, literally, their storage room is full of paper files, and it's a way to move it online. That was their sole motivation. Now, there's other benefits that come from it. So where people are in terms of data collection is all over the place. The reason why I bring that up is because in this world of, and this is bridging to the national, in this world of moving to shared accountability and seeing federal programs such as Medicare, Medicaid, VA, the DOD, other payment programs that play into healthcare or that affect healthcare, they're all moving to measurement and performance incentives. Well, in order to have the measurement and the performance incentives, meaning dollars flowing based on how the results of the measures are done, you have to have that IT infrastructure to collect the data necessary to do the performance measurement, to then meet the reporting requirements or qualify for payment. So there's a lot of work being done at the National Quality Forum, which is where I work, to look at what are the data elements that are needed that should be embedded in all electronic medical records or health records in order to build the infrastructure to collect the data, to do the measurement, to qualify for the payment. That's not something that could be done in Memphis or in Tallahassee. It really needs to be a national standard. So there's a lot of work heading that direction in terms of the backbone, and there's funding for the infrastructure locally. But there's a huge disconnect that I see between the conceptual of where people say we need to go at the national level and the readiness at the local level in terms of being able to implement that infrastructure.
Thank you. At the time we have left, I'd love to open it up to the questions of the audience. So if you'd like to suggest a question for our panelists or find out how to friend Diane on Facebook, please come on up. Yes, sir. Why don't you...
Hi. So my question is, this goes back to the choice under the sort of the moving trend towards ACOs and things like that. And I'm wondering whether or not, or what you think about how the new payment schemes or incentives to align incentives for quality of care and affordable care or high-value care are pushing, and ICD-10, are pushing more PCPs and primary care into consolidation with large acute care and large hospital systems, and how that affects choice regarding PCPs having sort of specific alliances with specific hospitals or specific delivery systems. For instance, I changed PCP from the time when I was 20 because I was most likely to be in a car accident to now when I'm 40 to some place where I might, heart disease is a better specialty, so that when I get admitted to the place it's going to. So that changes my, but how does the consolidation or the subsuming of PCPs under large hospital systems, which may or may not sort of benefit the low fixed cost of PCP care and the sort of conflict of interest almost of large hospital systems and what they want to do to PCPs in the movement of quality care to quality of care and affordable and high value care. Thank you.
Maybe Diane, you want to start?
Sure, just a quick comment on that. That is something we could do hours, days of discussion about. In fact, that's a huge issue, I think, that's being debated and discussed in markets. When I say markets, I mean just local communities, states all over the country. The new ACO rules came out yesterday. They went from 65 measures in the proposed rules to the final rules, including 33 measures. The rules also enabled, also recognized incentives for provider groups to be able to start their own ACOs, I think in recognition to the very issue that you're talking about. So I see it as positive movement where it seems that HHS has recognized that what they started with was forcing a type of structure that wasn't necessary, or frankly that was really disconnected from what was feasible in a number of communities. So there's financial incentives for providers to be able to create their own ACOs. They've changed some of the ACO expectations for EHRs to allow for, they've loosened it up a bit so it's not as restrictive, which means it's better able for providers to come together. How that's going to play out, I think, will be really interesting. Particularly, we need to pay close attention, I think, to where incentives are set. Because when you look at where dollar flows, whether it was when I was doing competitive intelligence or now the work that I'm doing with helping to provide input to HHS on what measures they should use for payment, right? Paying attention to where the dollars flow will get you the results, maybe that you want or you don't want, but dollars drive results, right? And so you follow the money. And I think to the degree that some of those incentives are about supporting patient choice or patient preferences, which is a new area of measurement, which is a new area of attention, which you've got to start thinking about how do we collect patient-reported information. I think that will start to shape how restrictive or not restrictive those accountability models are. So it's not a clean black and white, here are the boundaries, because I think some of the payment incentives will be driven by a recognition of what the patient preferences are.
Yeah. Would you like to make a comment?
Sure. I'd just like to comment in Massachusetts. I mean, we're living this in Massachusetts, and our state has made information available about cost and quality for different physician organizations and hospitals. And so, yes, the larger networks have higher prices. I mean, it's the Attorney General report, which folks can find on the AG's report, said that the biggest issue in healthcare pricing is, or the costs rising is around pricing, and the larger the system, the higher the prices. So it does make a difference. But to the issue of having this information available so people can look at it, the Health Quality and Cost Council here in Massachusetts has a website that has cost and quality information. We just recently did a study with Judy Hibbard, who does a lot about putting information to the public, and they tested this idea about do people follow price information, or do they follow cost information? Mm-hmm. And so the results of that study show that with the absence of any quality information or very low quality signals, people use price as a proxy for quality, and so we'll always see the highest price and go to that and say that's going to be the best, which obviously is not what we're trying to achieve. Interestingly, this study also looked at how you present price, and so many organizations, including the Mass Quality and Cost Council, use a dollar sign, as restaurants and hotels do, and yes, sort of a ubiquitous kind of thing showing price. That is the worst way to get people to focus on cost. If you have a dollar sign, people will not go to the lowest cost provider, even unless they have a really strong quality signal. If there's no quality signal, or if there's a low quality signal, and you use a dollar sign, they'll stay away from that. If you use actual dollar amounts, they're much more likely to say, okay, this is 125, this is 150, 175, maybe I'll go to the middle one. So there's so much we need to learn about sharing with the public about these kind of signals.
Excellent, thank you. Any other questions from the audience? Gentleman in the back, come on up.
Thanks very much. Obviously, thanks for the great work that you do. Logistics companies like FedEx, they're looking at sort of signals about how quickly they're doing things pretty much every hour, certainly every day. Yet in healthcare, which seems like it's awfully important, we're sort of looking at quality and then we're reporting it back to doctors 18 months after it happened. We're even looking at patient experience and we're reporting it back substantially later. What do you think the future is of trying to get signals in closer to real time to really make change happen in a rapid cycle basis?
It's a great point, Jeff. And so on our patient experience survey, we have been surveying every other year, which, is every 2 years to get feedback. It's obviously not good for quality improvement. So this year we're developing a survey for the physicians that will have ongoing quarterly feedback for the patient experience. And the cost was really prohibitive, but as we use the technology, the electronic modes of doing this, we'll be able to feedback faster. Likewise with the clinical quality in terms of having access to electronic health records as opposed to basing it on claims at the year end and then you wait till all the claims are reconciled and then I think we're moving there, not fast enough, but it's a really good point.
Diane?
We had an experience with that in the Pacific Northwest where the physician community was saying the very thing that you're raising. And they said, we're going to set up our own portal and we're going to pull together the information and be able to provide real-time information for physician decision-making. But they quickly discovered that without the electronic medical records in the preponderance of the clinics to be able to do that, they too were looking at health plan data, so claims data, which because of the lag time ended up being very old. And so they ended up stopping that process. I don't mean to sound like a broken record here, but our electronic backbone, our IT, our health information technology backbone is really important to allow the very kind of thing you're talking about, which is essential. And so that change will happen over time, but the more we can get that uptake and that implementation and create the incentives again for that implementation to occur, that will allow the really important real-time information to be available. A change that recently happened was the Medicare finally gave access to real-time data for every state in this country to access Medicare data. Now, those of you who have been following data sourcing and all that, that's huge. They made that access available to every state Medicaid program, specifically so that they would have real-time information to coordinate the care for people who are Medicare, Medicaid dual eligible. So that has been made available. That sounds great in concept, but having talked with Medicaid leaders from several states now, they say, yeah, we have access to that data. We can't get data out of our own systems about Medicaid, let alone knowing how to connect that data to the Medicare data, which is structured very differently, in order to pull it together to make it usable on a real-time basis. So again, baby step progress in the right direction, but there's a lot that needs to be done with the IT infrastructure so that that information can be pulled together in a way that it's actually usable for decision making.
Great. So we're running out of time. One last quick question from this lady here, and then we'll wrap it up.
Hi, Joyce Dostale, AWARE Technology. I just wanted to mention and applaud your moves towards quality and standardization. But I think that it's very important to remember that the ultimate buying decision, like so many buying decisions, is actually an emotional one. And I certainly know, growing up in a small town, many women went to the next county in order to have privacy over certain types of procedures or even investigation about a health concern. And I know now a lot of people are trying to get information about their physicians or their care team that have the same philosophy of treatment that they do. And these are dimensions that we're only starting to look at as part of that whole choice. So when people talk about choice of health care, they're really looking for something beyond just the dollars and the cents and the quality, but how does that provide me with a safe way to heal?
Yeah, I think that's a really good point. And the survey that we do asks, one of the questions are, do you respect the patient's preferences? And so there's some really important emotional, if you want to call them that way, or sort of care, compassion type questions that's included in the survey that's on our website. It's public, mhqp.org. You can look up in Massachusetts all of the primary care practices in the state. But that's a really good point.
Thank you, Barbara. Diane?
So if you tie to the presentation that we all just watched about multitasking, right? And I have my BlackBerry in this pocket, and I've got my iPhone in this pocket, and I've got my iPad, and I've got my Dell laptop literally right here with me today, and I think, oh my goodness. The ability to collect patient-reported information. So patient-reported information, not only about their experience of care, but about their preferences, and then factor that in so that it is available on the clinical side is really important. It also needs to be available to present information back to the clinicians to guide the care or their relationships. That's conceptually the direction that we're trying to go. There's a group, the Agency for Healthcare Research and Quality pulled together a group of 150 thought leaders a couple of months ago to really investigate the question of how do we engage the individual in the improvement of health care. And the report, which I actually should have been working on last night, instead of decided I needed to sleep, but the report that's going to come out soon, part of it has to do with looking at how do we gather and also provide information to people in ways that they feel comfortable with, and parsing out that information so that they get it real time in ways that they communicate, as opposed to something that's separate and stagnant from what people care about. And the whole notion of privacy and security in that process is paramount. And so there's much to go between here and there, but I do think I think there's a recognition of that need, but B, there's a need for each of you to keep your voices loud and clear about what's important in that regard so that it doesn't get lost in the process.
Thank you so much. We're going to be transitioning to our next panel. Thank you very much for your time, Diane and Barbara. Excellent. We'll be available afterwards.